Hi there, everyone. My name's Dr. Damien Rowland. I'm a paediatric emergency medicine consultant from Leicester, and I'm talking to Dr. Elizabeth Whittaker about travel histories. Elizabeth, can you introduce yourself?
Sure, I'm Liz Whittaker. I'm a paediatric infectious diseases consultant in London, who feels this is the most important conversation you ever have with a family, but I might be biased.
Okay, cool. So straight in there. So I'll be honest. I mean, I've been a consultant for over 5 years now, and I kind of remember a travel history from medical school. Do I use it often? I'll be really honest, I don't. So what can you do to convince me that actually this is something that those in acute and emergency care should be doing?
So I think that I agree. We don't need to do this on every child. But if I think if somebody's coming in with an unexplained fever, or at the moment with respiratory illnesses, it's worth just having a quick two-question check to find out if they've been anywhere interesting, because they could have an unusual infection that needs different treatment, or they could have at the moment a variant of concern for COVID or RSV, which we think is about to become a problem.
Excellent. So, one of the things that surprised me when I was preparing for this is um, the uh, the interesting aspect of that children actually might be a bigger reservoir for imported infections than I would have thought.
Yeah.
I know this study's quite old, but do you think it's still true?
Yeah, absolutely. And for us, we're normally really busy in September, October, because a lot of families take their kids home to their grandparents, and they never had travel vaccines when they were children. They now live in the UK, so it doesn't occur to them that they should protect their children. But the exposures over a summer in a rural part of another part of the world can be quite significant. And so it's just people. It's often visiting friends and relatives, and doing things that they did when they were children that don't realize have an impact.
Okay. So, why may children be more susceptible?
So the infections that are the most worrying are malaria, dengue, and typhoid, and these are the three most common things we see, which can be just much more severe in children. So malaria, in particular, which is kind of a non-specific fever, has a much higher mortality and morbidity rate, and particularly if they get cerebral malaria. And the same with typhoid. Untreated typhoid has a really high fatality rate, but actually is quite easily treated with ceftriaxone, our favorite antibiotic.
Right, I'm going to leave that for the moment. That's a whole other kind of pod or
Yeah,
podcast.
exactly.
So talk through. So you gave kind of two really quick questions that you can start
Yeah,
doing. But what are the things that you'd
yeah.
like to see
So,
us do in the emergency department that
so,
will help you later
so
on in the child's progress?
Perfect. So the screening question is, have you guys been anywhere in the last 6 to 8 weeks? And if they haven't, you don't need to go any further. But if they have been, it's where did you go? And then it's an understanding of incubation periods, because most things will incubate within a few weeks. So malaria and dengue and typhoid, if it's more than 3 weeks since they got back, it's very unlikely that's the problem. And then you might want to think about things like TB, which are less common, but they are easier to pick up. And then the clinical presentation. So the most common thing these kids have will be flu or RSV, but it's just worth bearing in mind that when they just have a fever and nothing else, I'm always a little bit suspicious, and that's when it's worth delving a little bit further. And when I say geography, were they in a city? Did they stay in an air conditioned room? Did they never leave the room? Did they just go to the pool? That's low risk. Did they stay with Granny in the country with all her animals, licking the sheep and petting the pigs? That's a problem. So it's just worth having that quick think about. And it can be that quick. It doesn't take much longer than that if you're used to doing it all the time.
Okay, and kind of incubation period. So let's. One of the reasons
Oh,
we're
yeah.
doing this is about kind of the potential RSV epidemic that we might be seeing that's been a bit delayed, or other bugs. So what are the timeframes that are important?
Yeah, so for COVID, as you know, it can incubate for up to 21 days. So anybody who's been traveling to red, amber, or green, I would not exclude any of them zones within the last 3 weeks and presents with a fever or another illness. We should just be aware that we might want to nurse them in a cubicle whilst we get a bit more data. We really just don't want some of those variants of concern spreading. And then RSV is very interesting because at the moment there's very little RSV circulating. It has to come from somewhere. It didn't come over in the winter. Was that because everything was closed down? So there's a massive opportunity to learn where RSV comes from, but also to maybe try and limit the spread. So we can ask families to kind of stay at home till their symptoms resolve. Incubation period for RSV, again, within 2 to 3 weeks. And mum or dad might have had a cold that they brought and then handed over. So remember that.
Yeah, and so that comes up to this kind of the last point about the presentations you're looking for. So I see a child perhaps who's got a fever, I can't find a source, and they tell me that they've been abroad in the last 2 weeks. What features of illness in either family members or contacts would you be asking about? Is it simply, has anyone else had a fever or cold? Or do you
Yeah.
need to be a bit more specific?
So no, I think so. It's for the COVID. It's the usual things, but for what we worry about with malaria and typhoid is that they can literally have very few other symptoms, and you actively have to look for both of those diseases, and that's quite screen. You can do a malaria thick and thin film or rapid test, which your lab will be able to do very easily, and typhoid it's sending blood cultures off stools as well, and things like that. But so you may have a family member who's had some gut symptoms for typhoid, and the malaria is the is just fever. So it isn't very helpful. That's why always talk to your local ID team who are more than fascinated in these questions.
Excellent.
Yeah.
I'm glad someone is. So we've covered a number of kind of some of these issues already. One of the things that we did at this, the kind of calculating the incubation period.
Yeah.
For RSV, so this is the thing that I suppose we're a bit worried about, and you mentioned that people bringing it in. So for RSV, what are the timescales that are important in terms of travel or other family members who have been affected?
Yeah, I guess what we haven't mentioned is, particularly for RSV at the moment, is that visiting friends and relatives. So maybe auntie or uncle have come back from India, Pakistan, Egypt. So the last three cases we've had have been Nigeria, Egypt, and Pakistan. So just remembering that visitors from overseas who've been and have had a cold can very rapidly pass that on. And so they may have been abroad in 6 to 8 weeks period and then been in contact with the family in the last 2 to 3 weeks. So that might be of relevance here. And there are some great websites that look at this, which we can put a link to at the end of the podcast.
Oh, brilliant. Excellent. We will do that. So last but by no means least, I wanted to use this discussion just to highlight a Peruki-led study. So this is a kind of a national network of researchers in children's emergency care in the United Kingdom and Ireland. But we've not seen RSV yet, and we're looking at doing a study where we pick a load of emergency departments, and they're just going to highlight to us when they start seeing children under the age of 2 who have clinical symptoms, and we'll follow them up for those who are admitted to see if they were positive. Why are we picking going up to 2? Because in the UK, we've classically only gone up to 1 year of age for RSV.
Because there wasn't an RSV season last year. So we normally see it most severely in the under ones because there's some immunity in the older age group. We do always see RSV in older children, but they tend to have less severe infection. But given that there wasn't an RSV season in the winter, there may be more affected toddlers this year. And so it's worth including them in our surveillance.
Okay, and one of the reasons I wanted to do this was to highlight the importance of the travel history, because it is going to be an important part of this study, is actually nailing down which of those families may have been abroad recently or in contact with someone who's brought it in. As you were saying, that we're only really seeing the positive cases that are coming in. When do you think things might really start? Are we going to see a summer surge, or are we just going to have it all delayed and have a horrendous next winter?
I think we'll probably start to see it in August. We're prepping in case it comes now, looking at the Southern Hemisphere data. But I think looking at the French data, they had a little surge in March. It's likely to just appear towards the end of the summer after everyone spreads around and circulates. But schools have just opened. We're seeing lots of rhinovirus. The RSV may follow. So just be aware and start thinking about it from now.
Fantastic. That's great to chat to you, Liz. Thank you very much for your time.
No worries.
And maybe we'll do this again when we've got some results to share.
Thanks very much, Damien.